from the shores of beautiful Lake Coeur d'Alene in the heart of North Idaho. Local, regional, national, and international guests discuss their topics on our forum, the North Idaho College Public Forum, with your host and moderator, political scientist, Tony Stewart.
I am most pleased to welcome you to a two-part series that's going to be addressing the question, what is long-term health care and how do we address this issue? In doing so, we're very pleased to welcome to our program Mr. Arthur V. Collins. Our guest is highly qualified to address both this week and next week this important issue as our population in this country grows older as far as the number of people over 65. Our guest holds a BA in philosophy from Gustavus Adolphus College in St. Peter, Minnesota. He holds a Master's of Divinity from the Pacific Lutheran Theological Seminary in Berkeley, California, and a Master's of Public Administration from Boise State University. He's had many years' experience dealing with healthcare issues and certainly represents a lot of people with his seminars and his workshops. If I may, Arthur, call you Arthur, and welcome you to our program. Thank you for taking this 2 weeks to be with us.
Good to be here.
And as always, I'm very pleased to have regular panelist Steve Schink, who is the Vice President of College Relations and Development at North Idaho College, and Steve will commence today's questioning.
Thank you. Art, I wonder if you just give us some general background information that might help our audience understand the scope of this issue of long-term health care that we're talking about. How is the population of the United States changing?
Well, we're changing very rapidly and becoming older is what it is. And there's a lot of statistic on that, and a lot of it has to do with the generation that is born between 1945 and 1964. They have the name called the baby boomers. And they're now reaching their ages about 50, late 48, late 40s, and that is the age wave which will literally transform our nation as we become older and older as a nation.
Just give us a few more statistics, if you would. I mean, what kind of a population are we going to see in 25 or 30 years, for instance, in terms of the number of people that, and there's one thing we all know, the older we get, and I'm one of that baby boomer generation, you start redefining the term old, but if we can agree for our purposes here that 65 or 70 is getting into that elderly category, what will the population look like in 30 years?
Yeah, I think at age 65, you're probably thinking about arriving is what you're doing, is probably another thing. Well, currently there's about 34 million people that are age 65 plus. And the projection are, if you go out 30 years since they know about what the population is going to age and the thing, we're looking at about 70 million people that will be age 65 plus. And that's a very rapid increase of aging. Give you another little statistic. In 1990, the people who were 100 years old were 32,000. They estimate that in the year 2000, the 2000 census is going to be that now the people who are age 100 will be 64,000. That's a doubling. That's aging very rapidly as a nation.
Now, I guess there's some good news. Not that the fact that people are getting older. I mean, we all get older every day, but that aging population certainly raises some challenges for us as a nation, as an economy. But I guess coupled with the fact that we're going to spend most of the next two shows talking about health care for the elderly, long-term care for us as we get older.
Yeah.
One reality is that we're a little healthier, too, as a society than we used to be.
Well, I think that when you see the age expectancy, rising, that's an indication of, we are healthier as people on the thing. That's a definite factor. I mean, if you go back towards the turn of the century, when FDR started the Social Security thing, at age 65, they didn't expect many people to live beyond 65. So there wasn't that much elderly people in their late 60s, it wasn't. So with the raising of the life expectancy, that's an indication of that we're just living longer. You listen to the TV and read the newspaper of all the different research that's going on with the aging process, how we can better make life more healthier, the nutritional programs, the alternative health care programs that are, we see it every day. there's a lot of stuff happening here on the thing, and it's only going to accelerate. You can call it entrepreneurship. People won't ask for it by the sheer numbers, particularly of the baby boomer generation. Not necessarily pick on them, but because the sheer numbers of it, they will just be given it, because it's just entrepreneurship of people that we've learned, the lifestyle we have here in the United States.
So, in other words, what we're saying here, and Tony may want to jump in at this point. Anytime you move toward politics, I know Tony gets interested in getting involved in the discussion. But and we're going to focus most of our discussion, obviously, on healthcare needs. But you're seeing the emergence of a powerful new group in America that are going to be older people, and that's going to impact us in a lot of ways. Mm-hmm. One more quick question for me, Tony, if I may. We all hope we're going to live for a long time and be healthy all of the years that we live, but what kind of a reality are we looking at when we start talking about long-term health care? What's the cost that's associated with that?
Well, the cost of long-term care, we can look at some present things, and the one cost level for long-term care that's been studied the most is nursing homes. Mm-hmm. Long-term care is far from just being nursing home care presently, but that's the one that's been studied the most. It's been the facility that's been around. The growth of nursing home care facilities started, the early 80s, about 83, and it's in the last 10, 15 years, that's been the growth factor. They estimate that the cost of nursing home care is rising about 5.8% per year. That's just a study. And currently... Which is, I mean, well above the general inflationary level for the economy. Yeah. So you look today's cost of nursing home care, it's about $40,000 a year. Here in our area, the average cost per day is $110 to $120 a day. That's the highest level of cost. But nursing home is just a tip of the iceberg of what is possible in terms of long-term care. It's surely not the only facility, and there's a plethora of long-term care facilities that have arisen just within our area within the last 2 or 3 years.
Thank you.
One other question on the political process, and then we'll get into, at least I will get into some of those areas. Steve knows me so well. It's my political science background. There's some remarkable research being done. There's a book called Age Power that's just out, and the author, I think, was extremely impressive with some numbers he gave. People living much longer, as you've indicated, and therefore, if they retire at 65 on Social Security, and if they live to be down the road not too far to average 85, and that's 20 years on Social Security, and it's more and more retire. Fewer people are in the workplace to pay into the Social Security program. And then you talk about the rising cost of long-term care, in which not only will people be drawing Social Security longer, but also the expenses that those Social Security checks will not cover those individuals who have to be in a facility. So somehow this country has to find an imaginative, creative way to address this economic question. And I have one more thing and get you to react to it. This particular author, he had something very fascinating to say, I thought, and that was that we are becoming very sophisticated at medical intervention to increase the length of life. We're not spending much on how much quality there is in one's 70s and 80s. And he's contending that that's an area to look at, because what time we live, if it can be a higher quality, well, it's more happiness, and then secondly, it does address this economic question. From your expertise and the work you're doing, are you optimistic or pessimistic as we go down that path?
I like to be optimistic about life. I think that we can respond to different challenges, as we see things happening. Just because we're aging as a nation doesn't mean that we're going the wrong direction or that's a negative experience. No, I think what we'll begin to see is a society that's user-friendly for the elderly, very user-friendly. When you can use a lot of statistics to mention how you see what proportion of the population will become aged as, again, the baby boomers as they age. It's going to be significant, very significant for the political process, for the economic process, the whole thing. I think one thing we need to do for simply a part of life is that maybe we need to rethink the FDR myth in terms that when I get 65, that I can sort of retire and that I no longer become a major taxpayer, because we limit income, see. So That's an issue that's probably going to have to be, we're going to have to think about this. What about mentorships in terms of the elderly? What about, that they can be training programs in terms of people that can learn these skills? We have a wealth a wealth of expertise in the elderly nation that sometimes we may be forgetting about.
So that's one of the many things that one can look at, and they're discussing also raising the age of Social Security retirement.
Yeah.
But we could do a whole program on that.
Yeah.
Let's move into
Okay.
the wonderful material you have in the knowledge. And let's just, for our viewers, define what is long-term care. What are we talking about? And does that always mean that it's within a certain facility, or is it at home? Just give us a somewhat broad definition of what we're dealing with.
Well, what long-term care is provides support for services that have chronic conditions, and they need assistance in what we call daily living activities is what they are. Long-term care deals with chronic condition, not an acute condition, because in acute condition you're getting better. But a chronic condition is something that you have to learn to live with and cope with for many, many years. And it creates limitations in terms of how I can function, and I may be dependent upon people for personal care to different degrees. The activities of daily living that are been standardized by the government, that have been standardized by the social services agencies are listed here: dressing, bathing, toileting, transferring, continence, and eating is what they are. Those are activities.
When you talk about that, are those always in a rest home of some kind of facility, or can there be more independent, staying in one's own home? What do you mean by that? Or to what extent, percentage-wise, does one have to anticipate that people will be needing very intensive care in a facility?
It depends on the health evaluation that happens within the facility or the health evaluation that is in the home, because it depends on what is the extent of the disability. This is really gets down to on an individual case-by-case basis, or situational.
Can you give us some kind of numbers of where we're at now and where we're looking going, and numbers that of people that will need to have the kind of care that requires an institution or facility to provide, rather than being able to continue in their home?
As far as numbers, it depends on the aging process. I really don't think there's been a lot of studies in that area, unfortunately, Tony. The only area that's been studied in terms of statistics is nursing home care, which is the greatest amount of care where you need 100% assistance. In the early 80s, nursing homes were a catch-all. People went there if they had a little bit of care or a lot of care. Now at our point in time is that nursing homes have become more specialized. So as far as studies has, number of people needing home care or needing nursing home, it's been tied to the nursing care facility. Facilities like home care, assisted living facilities, or residential care facilities, or adult daycare, those kinds of have not been studied much. We really have not. And it all gets down to, what is the health assessment of the person on the thing. But we're all going to get frail someday. The wrinkles will come, and that's where it begins to start in terms of how dependent I become on personal care from other people.
But because of the cost that we're talking about per year, around 40,000, and the growing population that's aging, I would assume we'd be looking at that more carefully, of the numbers that would have to have the special care, the chronic problems. In other words, what I'm attempting to say, is it correct to assume that there's going to be more encouragement that people can have independent living longer, that we'll be more cautious about moving into facility, that unless one is needing that kind of very, very close supervision and care?
I think it gets back, and maybe I'm being a bit evasive, but I think it gets back to a health evaluation is what it is. Because if a person, say, requires custodial care, which would mean maybe need assistance in eating or bathing, or it needs assistance in shopping, for example, okay, that kind of living experience ought to be more to assisted living facility or at home. Where a person is, say, has acute walking problems and needs a lot of support structure simply to walk around, then it may be the assisted living facility of 24-hour assistance, or even a nursing home where they're bed-bound or wheelchair-bound may be best appropriate for their living situation.
Well, Art, maybe what we can do is, especially since we've got 2 shows to talk about it, Can you take us through sort of a hierarchy of care that's available for the elderly from least to most? I mean, obviously, least is going to be independent living. You don't need any support at all. But nursing, that's at one end of the spectrum, and a nursing home, 24-hour care is at the opposite end. What's in between, and what are the characteristics of those different kinds of care?
Okay, that's a fair question. The greatest amount of care facility I think we know about is the nursing home, is what it is. And there's several facilities in the area that do that. It's the key on it is that the facility has a 24-hour RN, a registered nurse that's on staff. Mm-hmm. That's one of the biggest things. And they're equipped to meet people who need 100% assistance, what they are, okay, with chronic conditions. A step away from that is called assisted living facilities. These facilities are regulated and have oversight by the state. And they have different levels of care from, say, a little bit of care like custodial up to what they'd call maybe intermediate care. Probably not so much skilled care, but a step away from that of a nursing home. These are a home environment, but they're institutionalized, is what they are. And the principal thing that they're licensed by the state, and they have on staff a certified nurse assistant. Then another step away from that might be an adult daycare facility, where people that have need assistance and are dropped off for the day. A 9 to 5 facility that might have activities, meal preparation, and say medication assistance kind of thing. Again, here you have lesser amount of care for people because they're able to function somewhat, but they need the structure. Works very well for a husband and wife situation where you have a spouse that's disabled, enables to free up the spouse so she can go to work even, or to do something that is needed to be done, and the other spouse has the care structure. Another facility that's a very one-on-one thing is called adult foster care. Families adopting grandmas and grandpas, creating extended families. That the extended family is kind of a passé anymore, pretty much. But this can be either private or it can be regular. It can be a state have state oversight in terms of the level of care, with the parents there having certifications or training in certain levels of care as stipulated by the state. And they receive some payment of the state to help with the process of care for people on that. Then you have what we call independent living, which is independent. I'm just going to put that in quotes because this is a some care area where people desire to not live in a community by themselves. They want to live in a group setting, and then they can have much closer friendships with people, rather than have to get out in the car and go around, to meet their friends. It's a group environment. Okay, then there can be all kinds of assistance. Housekeeping is provided them. They could contract services for bathing if it's got to be if it's needed, or they could have contracted services that all their meals are prepared for them restaurant style in a very nice setting. There's several facilities like that. They're called independent units, but they're not totally independent. There's a degree of some care is what they are. And I think that these hybrids of some care, we'll probably see more of that, and it will be just kind of given to our age wave population. Whether they want it or not, they'll just get it because of the sheer numbers is what they are. We're going to have a lot of creative kind of elderly care situations. That's right. I really feel that we're looking at in the future, a society that's elderly friendly.
So the landscape for healthcare for the elderly has already expanded and is probably going to continue to expand.
Oh, yes.
I can't resist commenting on something from my own personal experience. You mentioned hybrid, and that's exactly what worked for some of my family members. Okay. 2 grandmothers and a great aunt who all went into a facility back in St. Louis, which is where I'm from. Mm-hmm. And when they went in, probably in their early 80s, they were all healthy, drove their own cars, and they could live pretty much independently. So they started out in a some care facility, which was almost like a big apartment complex. Mm-hmm. Lots of friends around, lots of activities, a very, very minimal amount of in-room service, a little bit of cleaning, I think, once a week.
There you go.
And 1 or 2 meals a day that they could take if they wanted to with other people, or they could cook in their own apartment. But there was also a provision within that same, and I believe it was Lutheran Homes Association sponsored, there was a provision for movement to gradually increasing levels of care as you became older and less able to take care of yourself. So they never left the same complex for the remainder of their lives, but they simply moved through levels of more and more intensive care until they passed away.
I think one thing that will happen, and maybe it'll happen locally, we'll see who the first developer that does it, was that we may have nursing homes right in subdivisions. It'll be a part of the subdivision, approved right in the facility. Someone's going to do that one of these times. I don't know who the first one's going to do it.
Well, it would be, and I'm editorializing a little bit here, but it'd be wonderful to keep families involved more. And luckily we were in the area. My father had passed away, but my mother was able to, she spent 3 or 4 days a week with the 2 grandmothers and my great aunt. So they had lots of personal association with family in addition to great care in that facility. But I mean, that seemed like a model that certainly worked well for our family.
These hybrid facilities have a unique thing to them. Say a person enters with some care area, and they're wings of the facility, but they're all are one unit is what they are. So in one wing, they say the person starts as an independence.
Exactly.
And let's say with the process of life or whatever happens, and you get into something, often pneumonia, respiratory diseases really gets a hold of the elderly so easily. They become very, very ill very quickly. Okay, they're in shouting distance away from the 24-hour care wing, which is the assisted living facility where you have a certified nurse assistant available. Okay, really at that point in time, they probably wouldn't even move the person. All they simply would change the cost of the rent and the services of the facility, and simply they're within shouting distance of care. And the friendships that they've established don't change. And I think that's important for people.
Very comforting. Thank you.
That is certainly brings to my mind that we are already being creative in the steps and processes that this aging numbers will dictate. One of the questions on that, and it has to do with the bridge I'm building to the next series of questions about cost, the fact that some of those particular types of care are so expensive that you've indicated tonight, and there are many, many people that cannot afford $40,000 a year, low-income families with their parents or grandparents. At one time in our history, the elderly stayed with their children until their death, and they got to be around the grandchildren a lot and so forth. And our society's really changed, and it's much more mobile, and families aren't always in the same community. But you see any of that coming back into play as these costs maybe? I'm continuing to be concerned about low-income families that have these rather large bills that they would face. Are we going to have some creative way of looking at how we can keep families together?
The days of the Waltons
is
what it is. Yeah, it's the extended family. There was a picture that I saw up in the Silver Valley, how it was, and it showed a family, just traveling from Miningtown to Minetown. This was, the late 1800s, early 1900s, and they built a pole tent, just like they used for elk hunting, on top of a wagon. And here they were lined up, and here was great grandma and grandma, and here was grandpa and grandma, and here was the kids and the parents and the kids are all lined up in the wagon. That's the extended family. Grandma got a little dementia, and just got a little confused. Took care of grandma. It's no big deal. Long-term care, this dementia thing, this has always been around. It's just we never lived this long. That's all. On the thing, there's been some talk about the necessity of going back in time to the extended family. I think there's some real problems we have politically, and just how we even organize society by planning and zoning. I have a little background in this thing because let's take one little thing here, which is we need a 3 thing. A lot of the planning and zoning laws say that we can have one unit on one piece of land. Well, wait a minute. Now you go to other countries, like for example New Zealand, no, they can have a second house on a piece of land, and it's the elderly cottage. Okay, why can we begin to think about this and changing? Because now we can create maybe extended family compounds. See, that's a rethinking of how we structure society. So going back to this and then that means that the children are going to have to stick around, because if you think about the Waltons, did they move away? Where are they going to move away to? No, they stayed. There's no place to go. Well, now there's so much opportunity. So what do we do for opportunity for the younger generation within communities? That's an economic question. That's a big one, in terms of employment and all this kind of stuff, and education and everything. So there's a lot of factors that have moved along and are working against us to go back to the extended family. But the extended family is how they made things happen in terms of the elderly. It really was very cost effective, but we're willing to work with that. You can look at certain pockets in the United States, certain ethnic groups that still do that, and they take care of their elderly. They do, yeah.
Maybe you have suggested a bridge where you say some developers may, in the near future, if they're building a housing project, they have a section within it that it's for retirement. But I heard you saying by that parents could move into that, and they can still be close to their children, grandchildren that may be in the same development, but still have their independence and be nearby.
There you go. That's a possibility. It depends on how we begin to value family, and what value do we put on the people that are older than I am. How we respect them. How do we want to actually grow old together? See, that's a real question for us. That can be a very pleasant thing. For other people, it maybe not be so pleasant. And when the person needs lots of care, then it's a matter of the tender, loving care of the family does it on the thing.
There's some evidence that when the elderly are around their grandchildren or around pets, they even bring pets into some of these nursing homes, that this is really healthy. What do you see from your work in that area? How helpful it is? And in fact, when we're talking about more quality care, one's attitude is important in one's health. And so are those support systems, like having the grandchildren around and having some pets, maybe cause people not to deteriorate so fast in their health?
That's, I think, important, because as a person maintains a sense of family, you have a sense of meaning and place in history. The question of it is, where does the elderly end up, though, in terms of our mobile society, where the children are living maybe 800 or 1,000 miles away? How often do they get to see their parents? So they kind of wither away in a lack of family experience. Our society is so mobile. So that's an issue that's a little hard to deal with, but I agree that maintaining some sense of family enables a person to have meaning for a person's life.
On that note, I'd like to bring the program to conclusion. On behalf of Steve Shink and our staff, we thank you, Art Collins, for being with us, and I would like to say to you very much thank you for coming back next week when our viewers will get to hear us continue. We'll talk about such things as who pays the bills, the costs, things like Medicaid, Medicare,
that's important.
Insurance, long-term insurance, so forth, and we will deal with that. And we look forward to it. You are gracious to give us this time. Ladies and gentlemen, we are discussing what we think is a very important subject, and that has to do with long-term health care. And as I just indicated to our guest, we've invited him back next week, and he's accepted that invitation. I would like to invite you to be with us at that same time when we will continue to discuss this issue. Until then, please have a good week. I am Tony Stewart.
North Idaho College Public Forum is the longest-running public television show of its type in North America and is seen in 7 states and 2 Canadian provinces. Each episode is pre-recorded live and is an educational community outreach from North Idaho College. Please join us again at this same time next week for another new edition of North Idaho College Public Forum on this public television station. From the shores of beautiful Lake Coeur d'Alene in the heart of North Idaho. Local, regional, national, and international guests discuss their topics on our forum. The North Idaho College Public Forum. With your host and moderator, political scientist, Tony Stewart.
It is my pleasure to welcome you back to our second week of a topic called long-term health care. For you who were not with us last week, our guest is Arthur V. Collins, who is certainly highly qualified to discuss this important issue. And last week we talked a lot about how our demographics are changing, and the population of our country in the 21st century is going to be a larger percentage of elderly citizens, and what that means to their care and where one might live. Our guest holds a BA degree in philosophy from Gustavus Adolphus College in St. Peter, Minnesota. He has a Master's of Divinity from Pacific Lutheran Theological Seminary in Berkeley, California, and he holds a Master's of Public Administration from Boise State University. Arthur, welcome back for a second week, and you were most articulate last week, and we learned a lot about where we might be heading in the future. Thank you for returning this week.
It's good to be here.
And as always, I'm pleased to have our regular panelist, Steve Schenck, who is the Vice President of College Relations and Development at North Idaho College, and Steve will commence today's questioning.
Thank you, Tony. Welcome back, Art.
Okay.
I thought I'd take just a second or two to briefly touch on some of the things we discussed last week, and then we can jump into a little more meaty topics. Certainly, we talked about the aging of America. I think it's a phenomenon that's gotten a lot of attention in the media. I was certainly surprised to learn that in 30 years there'll be 70 million Americans age 65 and older. We talked a bit about the types of long-term care, everything from minimal care to total total nursing care. The cost, an average cost for nursing care today of $40,000 a year, and that cost is rapidly rising. Mm-hmm. On the plus side, Americans are living longer, they're living healthier, and there's beginning to emerge a lot of different options for health care as we get older. But as we get down to more specifics, Art, I thought we'd ask you to talk just a little bit about who pays for this very significant cost of long-term care as things stand today.
If you look at who pays the total bill, like across the nation, not on a macro scale, not micro, Medicare pays about 9% of the bill. These are pretty much statistics that they know. When you have long-term care insurance, it's so new, and Medicare supplements, they only pay about 3% of the bill. The reason it's so low is that they estimate that only less than 5% of the people in the United States really carry long-term care insurance. So this is a new phenomena with people's realization of planning for the worst and hoping for the best, as it were. Medicaid, which is health care assistance for low-income people, pays about 40% of the cost. Other government entities like the VA, Veterans Administration, they pay about 1%. This concerns like POWs and veterans that have a purple card because they've been disabled through the war. But the bulk of that's paying for long-term care is the citizen. That's about 47% on the thing. There's a lot of meanings attached to these figures, but essentially the bulk is being paid by the average citizen.
So, Art, you throw the percentages aside. What's that tell the average American who may be thinking that as he or she gets older, the government is going to take care of their needs?
Well, there's a lot of stuff to talk about there, for sure. One of the things that's happening is our tax base is changing so rapidly. And you have to get a little handle on that. In 1945, there was 40 workers to one retiree. In 1995, there was 3.4 workers to one retiree. And in 30 years, out to 2035, it's 2 workers to one retiree. What's happening to the tax base? We have an entitlements to the federal budget is about 41%. And we're really struggling with those entitlements, and that has nothing to do with long-term care.
So we're getting dangerously close to that political science topic that we warned the audience about last week. Maybe that's the reason we're spending so much time debating Social Security reform and national health insurance and that sort of thing. Art, and I don't want to just start a topic that will take us the rest of the show. But what kind of advice are you giving to people as to how they can take more control over the quality of their life and the quality of the care they're going to receive as they get older? What kinds of things can people do today to help improve their outlook as they age?
Well, I think there's 3 choices with long-term care. And this is as we decide we're going to plan for the worst and hope for the best. I can simply pay it with my own resources. I just open my checkbook and start writing checks, as it were. But you begin to realize that when you look at the cost of this stuff, this gets pretty expensive.
Big checks you're going to be writing.
Big checks, yeah, because we're dealing with chronic conditions that may go over for a number of period of years. People have to learn to live and cope with this thing for 5-10 years. And when you deal with nursing homes of $40,000 a year, assisted living facility costs, which is a step down away from nursing home is $25,000 to $30,000 a year. And then you start projecting this out in terms of rising cost of care, we get into astronomical figures. Okay. The other option, we can say we're going to let the government take care of us. Well, then we lose control of our care. We really do. Because I'm saying what's good for the government is good for me. And remember that Medicaid and Medicare are political structures, that these rules change. Depends on what's going out there in terms of the limited resources we have for taxes. And you begin to see what's happening to our tax base. We're going in the wrong direction. We're getting too many retirees and not enough taxpayers. We're going in the wrong direction. Third option is to be insured. Here I take control of my life. I simply decide that I'm going to, decide what is important for me. In being insured, then what I have to decide is what risk I want to transfer to the insurance company. I may transfer 100% of the cost, or I may transfer only 80%. It's an affordability question. It's a life decision. It has to do with my value systems, what I want to do with my life. But I take charge of my own destiny, and I decide the level of care that's important for me as an individual, or is important care for my spouse.
Thank you.
Also.
Another question that arises from your work and your presentations is, and you've mentioned it briefly this evening, or actually this is airing of a day, we're taping at night, that do I really anticipate needing this, or who's going to need it in the future? Some people don't ever find themselves, in fact, there's tragedies where people die of accidents or heart attack, whatever it may be, but how would you address someone who might anticipate they would not need it, and we can't forecast the future for ourselves? What would you say to the general population?
We've already made a somewhat of a decision that we plan for the worst with major medicals. That's a decision that a lot of people are making. In other words, that major medicals then help me to keep out of the disaster that would ruin me. The $100,000, the $300,000 bill, with some total disaster of health or accident kind of thing. Okay. The other facet of that is long-term care. That's all it is. That if I get into a disaster, whether it be the catastrophe of life or it's the frailty of life, that it goes along with the major medical long-term care. But the significant thing is that the major medical and long-term care are both primary areas. One doesn't pay, they're not supplemental to each other. Major medicals just don't pay for long-term care for chronic conditions. They just don't. So what we have here is something has arisen because of we're getting older and we're getting lots of us. See, in the past this has never happened. This is something else that is going to be something else to see, and I hope I can live long enough to see a little bit of it, see what it's going to look like. I don't know. But it's going to be amazing to see when you see 70 million people, maybe a quarter to half of the population elderly, all got gray hair. It's going to be really interesting to see this. But okay, now we've got the situation that we plan for the worst for medical expenses. We've been doing that. Now, because of the elderly question, things have changed. So that long-term care becomes just an extension of planning for the worst that goes along with major medicals.
This brought another question in my mind about who pays. Suppose someone's getting rather elderly, a couple, and it's obvious they're going to, before long, need this kind of very careful care, maybe in a nursing home, and their assets have to be taken, to pay the monthly bills. Maybe they have a home and so forth. Yeah. But in some cases, I suppose what is happening that they turn all their assets over to their children sometime before they go into that care center. So what I'm thinking in relation to that, to try to protect those assets for their children, but doesn't that shift back to the government if they don't have that money to pay? So I'm throwing another problem into this process. And so and that could become a trend also.
Manipulating assets is a person has to be very careful here, because manipulating assets to qualify for Medicaid, which is that the government's going to take care of your long-term care. That one's you can get yourself in real trouble there with jail and fines, because the government can look back on this, say as much as 5 years or more. I mean, don't say it's only 5 years. They can look back on from the day that you apply for government assistance with long-term care.
So look at the pattern of what you might be trying to do.
Yeah. What are you doing? Have you been manipulating those assets? That can be real scary, and it can also be a significant penalty for the person that gave them that advice, not just the person that did it on the thing. So I think that's to be real careful. Again, if you're going to start transferring and manipulating assets, are you really taking charge of your own life in terms of care for yourself or care for your spouse, or to what extent I'm going to be more responsible for the care within the context of family, because it goes to children, and everybody on the thing. So the question is, how much am I going to take charge of my life? Is the issue, I think.
And we talk about the cost and the pay. The numbers that you've been using, that, for example, $40,000 a year, does that also include medication, or is that just the price of being housed in a nursing home?
That's just the basic kinds of costs. I mean, there's other kinds of costs that's going to be involved in there, because you've got services costs, and those are all depends on the facility. But if we just take a look at the basic costs of $40,000, and maybe even more than that, when you actually get to the facility and determine what's needed on the thing, this gets to be a real question of affordability.
So that $40,000 not necessarily the bottom line.
Not necessarily. No, it's not.
Steve Sheen.
Art, it's clear to me sitting here, and the audience has got to be looking at this group and saying, okay, here's three guys who ought to be interested in this, because they're not that far from retirement themselves. I'm speaking for all of us. And I think the audience is with me on this one, Tony.
Well, we can take a poll on that.
I've never even given it any thought. I mean, certainly okay. I'm thinking a lot more than I did 10 or even 5 years ago about planning for retirement, but I haven't thought at all about planning for long-term health care needs. And I think the reality is most of us, those of us who are lucky enough to work in a profession that provides for our immediate health care, typically think in terms of providing for health care,
there you go.
Not long-term care, health care through our working years, and plan on, having enough money from retirement and savings to try to maintain our lifestyle after we quit working, and then plan on a rollover from employer-provided health care. Again, if there are millions of Americans who don't have any, but those of us who do, to government-assisted care. And now we've started thinking about supplements, Medicare, Medicaid supplements. This is a whole new field nobody thinks about. A couple of things crossed my mind. One, you've given us some great information here, but this is not just long-term care issues are not just a problem of the elderly, are they?
No.
There are a lot of people who need long-term care who aren't old.
Yeah. Let's say you get the mining disaster, the rock burst in the mine. Okay, how long is a person out of circulation with society? Maybe a year. I don't know. It's a disaster. Or a person, you get a person that goes down the wrong way on a freeway, rams into you. What do you end up with? Well, you end up with needing personal care. There's a level of time where you're going to need some assistance from other people. And is that going to happen in the extended family? Well, that's a question. See, we've kind of gone away from that. So we're buying. We have personal needs. So then it comes to starting writing checks is what it has to do on the thing. So long-term care is not just an elderly frailty issue. It has to do with simply disaster planning. I've said this before, but we always hope for the best and plan for the worst. Yeah. And that's what long-term care is. It's planning for the worst.
And if you need a statistic to back that up from your brochure, 40% of the people who are receiving some kind of long-term care today are between the ages of 18 and 65, not 65, 75, 85 and older.
That's a surprising statistic, but that's it.
Here's something else to think about, and I'm going to ask you to speculate a little bit because I'm not sure you came prepared to talk about this, but it's certainly related.
Okay.
We said earlier, either in the last show or this show, I think it was this show, that the ratio of currently employed workers to retirees is shifting dramatically from 40 to 1 in 1945 to a projected 2 to 1 in 2035.
Yeah.
Another statistic that I came across recently is that America is going to be facing fairly soon a real shortage of trained workers, working adults, to the point where we may have to look at either exporting jobs or importing workers. And one of the things that's going to force us to do, as you discussed in our last show, is rethink the notion of retirement. And employers are going to be looking for ways to retain talented workers, current workers of retirement age. They're going to want to keep them working longer. I'm just wondering is there any movement at all, however seminal it may be, are employers starting to take a look at providing different kinds of insurance coverage, even long-term care insurance coverage, as an incentive to attract workers, retain workers. Have you seen anything like that in the workplace?
I think the long-term care as a part of employee benefits, along with the major medical, is being approached by employers. It's slow, and it's, I think if employers begin to think about it, okay, let's say that an employee gets involved in long-term care, either with a spouse or a relative, okay, who's going to be the winner on that one. Mm-hmm. It's not a choice between blood and employment. Okay, the employer is there's going to be some lost time. There's going to be a distraction, or there's going to be some absenteeism and kind of things that will affect the employee's workability and efficiency. It's going to be there. Okay, I think that as we begin to see, we get more and more elderly with our population, and I think the employers are beginning to see that as recognition that this is a viable means of employee benefits is what it is. Now the question of it is, it's the affordability of the employer. Mm-hmm. That's a big issue, because major medicals for the employer are very expensive. They really are, and it bites them pretty hard.
Well, it's not uncommon in our industry to see people who've left one career, who already have a fairly stable source of income, who are starting a second career and working, and you ask them why, and it is primarily for the insurance benefits. They're talking about health insurance, but I could see this evolving in the future.
The one thing to mention here on this cost with employers, so they understand that when you deal with insurance costs of long-term care, it's risk rated by chronological age. In other words, as you get older and older and closer, say, to use it, the premium would get higher as you consider it along the way of life. But again, when you're looking at relatively a younger age, long-term care is not prohibitive in cost. It really is not, because you may not use the policy for like 30 or 40 years in terms of a disaster or the frailty of age. So the earliest on that you start looking into this thing, the better you are, because we never get any younger.
Well, and if Tony will permit me another couple of questions, that's one of the things I wanted to ask. I mean, we've already established the fact that saying how much long-term health care insurance is needed is a tough question for you to answer.
Yeah.
But if a person starts looking at this around our age, 40s, 50s, let's say, hopefully still a long way from needing long-term care, how much more affordable is it as opposed to waiting until you're 65 or 70?
2 times, factor of 2, it may well be. And because see, that when you look at how the cost will go, it's not a straight line curve. It goes, it makes it, because you get in your 70s, 80s, and these costs of the thing, it's risk rated by chronological age. The insurance companies realize this in terms of the risk, and it's just a risk factor. So that the earliest on to look at this in terms of cost is the younger you are, the better is a good time to start looking into it.
Typically, from what little I understand of the insurance profession, it tries to make insurance affordable by spreading the risk over very large populations. Yeah. And I would think that right now there's not a large population. I think you said less than 5% of the population carries long-term care insurance.
Right, that's about right.
Is there a chance, Art, that we're going to see rates go down as more people get involved in this pool? Is that something we could hope for at least?
That's a real tough one to deal with. I think basically what the insurance industry has looked at that chronological age in terms of rising cost of care. The nice thing about long-term care insurance, though, that most of the better policies that the premiums don't raise with increasing age or usage. So when you lock into something, then it doesn't raise by as you get older. So that's a big factor. The one issue for raising of premiums will be that they can raise premiums only for everybody in the whole state. It's a claim question. Because there's been not that many people having long-term care, and we haven't had that much aging population yet, the insurance industry really hasn't paid a lot of claims in long-term care. It really is not. We really not tested that out. So we just don't know what would happen out there in terms of the rising cost of premiums for long-term care. Just don't know.
Can I ask one more quick question? And I think this one you could probably answer for us pretty quickly. What about availability? How strictly are insurance companies looking at individuals and their medical history in saying, yes, we'll sell you insurance, or no, I'm sorry, you're a bad risk. We're not going to write this policy on you?
Yeah, there's a definite risk rating that happens by medical condition as well as by chronological age. But the interesting thing with long-term care, it has to do with stability, not whether you have a condition or a chronic condition, is to what extent you have been stabilized over a good period of time. Is it 6 months or a year or 2 years or 9 months, what it is. So the risk rating is not so much by that I have had a bypass. See, I've had cancer in the past. Well, with a major medical, it's different. Well, with long-term care, it says what has been the stability here of this time. Have you stabled out into thing? And that's a very different approach.
Thank you.
I'm sure, Art, that we have some viewers that are very eager to hear some numbers. They know what they're paying on their health care insurance,
Yeah,
but
I know.
if they were going to shop for this kind of insurance for long-term health care, what kind of dollars are they talking about a month or a year? I know it depends on those factors you said, but can you give us some numbers that they could consider?
This is really, really hard for myself to do this, and I'm going to probably be a little evasive here. I think it gets down to the fact that a person has to look at one question of affordability, and the question of it is how much risk I want to take on versus how much risk I want to transfer to the insurance company. And there's a lot of different ratios here. Some people says that I don't even want to mess with the cost of this thing. I'm going to transfer 100% of all the costs for long-term care to the insurance company. Well, those premiums are going to be higher. Then a person says, affordability, I can only transfer 75%. I'm going to pick up 25% of it. See, okay, that's affordable.
Kind of things.
Yeah, I think there is no one way to do it.
Well, that's what happens though in healthcare too. Some corporations and institutions, you have 80% coverage on the health plan. You cover 20%, or something.
It's related to that.
Yeah,
it's related to that.
But not being stubborn as I am, I want to consider that a little further for our viewers. I'm defending my viewers. When the average family they may, if they have group health care, they may be paying, they and their employer, $400 or $500 a month. If you're on your own, a couple might be paying for major medical coverage with very little deductible, maybe $1,000 a month. Are we in the ballpark there in this, or is it in any way that the same, or is it different for long-term health care? I just like the viewer to be able to grasp a hold of, are they somewhere in the same area of the cost of this insurance?
I'd say the younger you get with long-term care, it's going to be much more affordable than a major medical.
It would be.
Yeah, I'd say the best I can say is investigate it at the youngest age possible.
If one is older and they're listening and they want to still do this program has really got their attention.
Yeah.
Then they would pay more on the average than what they pay for major medical.
Well,
is that correct?
It may not be. Depends on the level of risk that they want to transfer to the insurance companies, because it gets affordability question. See, let's say a person decides to plan for the worst and develop a plan, and say they're playing out that because who knows how it would happen. But let's say they're going to plan out for, say, 20 years they might use the policy. Okay, in that span of time. But at this point in time, they're age 60 or whatever they are, because if you get to be 60 or 65, you got good health, you're going to be around a while. There's a lot of statistics on that. You got good health, you're going to be around a while. So they're paying a certain point of cost there on the thing. And I would say it's a question of how much do I want to shoulder myself, the thing. And it gets down to, like Medicare supplement policies for people age 65, good plan runs right about $100 a month. That's pretty standard. You can see that very easy. People age 65, good plan that will run about that. So I say long-term care, we're probably looking, in the neighborhood of a complementary cost. If you're 65, say, maybe a little bit more on that. Depends on the level of risk that you may wish to transfer to the insurance company.
That's really helpful. Thank you, Art, because a lot of people could afford that in that area. I just wanted them to have some kind of numbers. Of course, they would have to consult with insurance companies and get all that information.
The thing that's interesting about long-term care is that in no way are you going to pay premiums that will equal the benefits. No way.
Right.
There's going to be a huge disparity on that. So the way you begin to evaluate this thing is try to get the widest disparity as possible. Only makes sense on the thing. So that's why you need to shop around, ask a lot of questions, and speak and have several different proposals in this area, because there's a plethora of options to work with.
And I assume that by state law and insurance policies and so forth that if you've been on it a good long while paying the insurance and you go into a facility that insurance would not be canceled. Would there be provisions to make sure that didn't happen?
Yeah, you want a policy that's guaranteed renewable, which means as long as you pay the premium, that the policy benefits will be honored. That's one of the facets of guaranteed renewable.
And
you want a facility that's going to be around a while.
And the quality of the company?
Yes, I think you need to ask some questions in terms of solvency, how big is the company, and those kind of things are, and find out as much as you can about the insurance company that is offering this plan for you. That's very important because you want a company that's going to be around a while.
That's crucial. And on that note, we have to bring the program to conclusion.
Okay.
Art Collins, on behalf of Steve Shink and our staff, thank you for being with us. You've been a wonderful guest the past 2 weeks, and I know that by the fact that you've informed our viewers on so many important issues that people will face or already are facing. Ladies and gentlemen, I thank you so much for watching our program today, and I do believe it has been informative for you. And I would like to invite you to be with us again next week when we're going to move to yet another issue. Each week we try to bring you topics we think they're very relevant to your life, and we appreciate the opportunity to come into your home or your business for this program. And again, as I indicated, we will turn to another topic next week. Until then, please have a good week. I am Tony Stewart.
North Idaho College Public Forum is the longest-running public television show of its type in North America and is seen in 7 states and 2 Canadian provinces. Each episode is pre-recorded live and is an educational community outreach from North Idaho College. Please join us again at this same time next week for another new edition of North Idaho College Public Forum on this public television station.